السلام عليكم ورحمة الله وبركاته، وحياكم الله جميعا في محاضرتنا اليوم على البون physiology والosseo-integration as part or lecture that is part of the dental implant course. Okay, so today inshallah this is our outline and this is our intended learning outcomes. We're going to discuss a little bit in our introduction a few terminologies that are important to bone development and bone resorption, and which mostly relates to the physiology of the bone. Then we're going to discuss the structure of the bone, and then we're going to classify the different types of bone in implant dentistry. We'll be also discussing osseointegration, which is the connection between the implant and the bone surface. We're going to be talking a little bit about the bone implant interface, and last but not least, we're going to discuss how the soft tissue, the gingival sulcus, forms around the abutment of the implant itself. Okay, so our lecture today is mostly from two books. We have chapter 4. This is very important reading material from Clinical Periodontology and Implant Dentistry's book. And we have chapter 74 and the 13th edition of Kranz's Clinical Periodontology. Okay, so what is bone? Bone is basically composed of an inorganic, which is mostly minerals, and an organic component, which we mean by the organic component is the matrix, the cells, and the collagen. The bone matrix is mostly composed of collagenous and non-collagenous matrix, and the function of bone in general is to resist load. Okay, it acts as a reservoir for minerals when we need them, and it protects highly sensitive organs from external forces, just like, the chest cavity protects the heart itself, the skull protects the brain tissue. Okay, so what is the structure of bone? Bone, the matrix itself is mostly fibrous and contains minerals, and you have a mineral content which is mainly calcium phosphate and makes about 85% of the mineral content. We also have calcium hydroxide and about 10% of calcium carbonate. When the calcium phosphate interacts with the calcium hydroxide, there will be a new crystal that is formed. It's called hydroxyapatite. Hydroxyapatite is a very solid structure, and it provides the strength of the bone. So if we look at this image right here, we're going to go from, on the left is the microscopic structure of the bone, all the way to a whole bone, which is the macroscopic. So how is bone arranged? If we take a segment of the bone, it's called a fibril. The fibril itself consists of collagen molecules and enzymatic cross-linking, and we can see the hydroxyapatites forming and being linked with this collagen. So once we have these fibrils being stacked upon each other, there are also some more enzymatic cross-linking. This will form a fiber array, and when you stack fiber arrays on top of each other, we're going to have lamellae forming in a circular fashion, and lamellae mostly surround Haversian canals. Haversian canals contain the arteries, contain the veins, and contain the lymphatics that is important for the vitalization of the bone. Okay, so when we have these whole structures beside each other, we will have the whole bone structure completed. So this structure is important because it explains how things are arranged on a microscopic structure. When we look at the histology of the bone, we said that besides matrix, we have cells. So what are the main cells that are available in the bone? We have osteoblasts, which are important for secreting the organic constituents of the bone matrix, and they mostly form the bone itself. We also have osteoclasts, which are multinucleated, okay, and they're responsible for resorbing the bony matrix from the bone surface itself. And we also have osteocytes, okay? Osteocytes are impregnated within the bony structure itself, okay? These osteocytes are a form of osteoblast, but they are entrapped in the matrix itself. And we have osteoprogenitor cells. These are like stem cells. They're undifferentiated, they're unspecialized, and depending on the signals they receive, they might go into mitosis, okay, and they might develop into osteoblasts, or they might develop into osteoclasts if the bony structure requires that. So bone in general goes through, it's a living tissue. It's in constant remodeling within the body itself. And this remodeling occurs due to systemic factors, hormonological factors, environmental factors, and physical factors that affect its shape. So modeling is, if you look at the picture on the right, it's a surface-specific activity which might lead to either apposition of bone or resorption, okay, and changes the initial bony architecture, while remodeling represents the change that occurs within the mineralized bone without alteration. So the bone is going to maintain the same structure, but it's going to go both through either resorption and back into bone formation, but the initial structure is not changed. Knowing these two terms is very critical to understanding how the bone behaves. So with any bone remodeling, this is an example on the left. If you have a trauma, you have hematoma forming, you have blood cells going into the site, you have undifferentiated mesenchymal stem cells, and a lot of things that are happening at the same time, okay? First thing that happens is these cells become activated, okay? And their job is to remove any necrotic tissue. So this is mostly the job of osteoclasts. They become activated and they begin secreting acids to remove either the resorbed, fractured, or the necrotic bone. And then the process of osteoclastic resorption occurs. Once that is achieved, we have the development of a fibrocollagenous callus. A callus is initial bone that is undeveloped, it's still unmineralized, and then with time we have the callus forming. We see initial processes of mineralization, and then bone remodeling occurs to develop the structure and the initial architecture of the bone itself. Okay, so what is a bone multicellular unit? A bone multicellular unit is basically a description of what occurs during the process of bone remodeling. You have two processes in this unit. You have resorption and bone apposition. Okay, first thing that happens is within the first 3 weeks of the trauma itself, we have pre-osteoclasts or undifferentiated stem cells, mesenchymal stem cells, that through signaling factors, through interleukins, through certain bone hormones like progesterone, hematopoietic stem cells, and also through bone morphogenic protein might be differentiated into osteoclasts. Okay, and this is where we see the process of resorption starting. Once that process is ending, we go through a reversal phase at approximately 3 weeks. We have pre-osteoblasts that come to the site, and they start secreting the callus to form or to repeat the initial architecture that was there. These osteoblasts will then, we will see the process of mineralization that extends up to 3 months, and it might extend to even 18 months. Some of these cells will be they will remain within the structure of the bone, and we start to call them osteocytes, or on the surface of the bone itself. Okay. So growth factors in general are biological mediators that regulate the process, the cellular events that happen through either bone resorption and bone formation through binding to these specific cell surface receptors. Okay. Once they bind, these cells go into mitosis, go through the process of development, and become the cell that is responsible for the task that is required. Healing of the bone itself is also regulated by growth factors and other cytokines. Okay? Bone morphogenic proteins are extremely critical. أنا أحب أشبهها بالمفتاح، المفتاح اللي يشبك في القفل عندنا القفل هذا اللي هي السيل اللي هي undifferentiated mesenchymal cell، مجرد يجي عليها البون مورفوجينيك بروتين او البي ام بي تتحول هذه الخلية إلى خلية ناضجة من undifferentiated to a differentiated osteoblast that is involved in the process of bone formation. يوجد أيضا الآن medications available. البون مورفوجينيك بروتين أيضا متوفر كمنتج تجاري ويستخدم في تطعيم العظم بشكل عام، البروسيجرز اللي لها علاقة بالregeneration of bone. Okay. Skeletal deformations, development of osteoporosis, reduction في mineral density، حتى الفوليوم كلها associated with some problem in BMP signaling. Okay. Types of bone، طبعا عندنا lamellar bone، فاكرين لما تكلمنا تصير لاميلا يعني شرايح. اوكي، اللاميلا هذا عادة يجي اما compact or يكون cancellous or spongy. وعندنا non lamellar bone، هذا الwoven bone، هذا البون اللي يتكون في المراحل الأساسية للهيلينج. اوكي، but it's still not as mineralized and as dense and lamellar as compact bone. And then we have bundle bone. Bundle bone is the bone that is specific to the area of the periodontal ligament. نشوف فيها Sharpie's fibers, the periodontal ligament fibers being inserted within the structure itself. Okay, so لو تلاحظون هذا tooth على اليمين، هذا cemental layer. Okay, and then a periodontal ligament. The periodontal ligaments, some of these fibers will extend into the bone, forming the bundle bone as seen in the histological image in the picture. Okay. الأسماء الثانية للبندل بون، okay، أكيد تعرفونها، اللي هي اللامينا دورا. okay، اللامينا دورا، بس اللامينا دورا هو وصف radiographic لنصف ال appearance of the bone surrounding the periodontal ligament. Okay. Lamellar bone is mostly the principal loading bearing tissue of the adult skeleton. شايفين هنا الهافرجن canals كلها لما تبدأ تتنسق على lamellar bone. These sheets of bone provide strength. Okay, it forms very slowly compared to the woven bone. It's mostly perpendicular. It's the predominant component of mature cortical and trabecular bone. Lamellar bone histologically similar regardless of the age at which it forms. Okay. ونلاحظ في كل bundle عندنا الأوستيون which is the bundle، وداخل البندل عندنا Havergen canal. Okay, these are extensions of the blood vessels within the system of the bone itself. Okay, so this is mostly compact bone, very strong, okay, and highly mineralized compared to a spongeous bone, which we see spaces for bone marrow. Okay, woven bone زي ما قلنا highly cellular tissue formed very rapidly at about 30 to 50 microns a day, and it's a response to growth or injury. It has a low mineral content, more random fiber orientation, and we do not see the similar structure as in the lamellar bone itself. Okay. Serves as an important stabilization role in the healing of implants. So once we place the implant, the first type of bone that is going to be deposited on the implant surface is going to be a woven bone. So we discussed woven bone is characteristic of ligament and tendon attachment. There's striations and oriented across the underlying lamellar pattern. These striations are extensions of Sharpie's fibers, and they're composed of collagen bundles from adjacent connective tissue that is inserted directly into the bone. Okay, so microscopically, زي ما قلنا, this is compact trabecular, and this is cancellous, woven, or spongy. You can see it's highly vascular, fibrous, and less histologically developed than what we see in lamellar bone. Okay, so this is the osteon, and inside the osteon we have the Havergen canals, which provides the blood supply. Okay, so compact bone is made up of lamella زي ما قلنا, وعندنا في المنتصف a spongy bone. Okay, they're arranged in the form of concentric rings and they're surrounded by a narrow haverging canal present at the center of each osteon. The cancellous or spongy bone contains spaces filled with mostly bone marrow. Okay. So we discussed the physiologic structure and also the anatomy of bone that is present in the body itself. So can bone volume be affected by systemic factors? The answer is absolutely yes, because we might have hormonal changes that affect the density, the porosity. We have diseases like osteoporosis, we have diabetes mellitus, that all affects not only bone but also tissue. Okay. So we have to differentiate also between osteogenesis, osteoconduction, and osteoinduction. Genesis means directly forming. So if we take an autograft from a patient and place the bone in its other place, we are moving the same cells, the living cells, to another location. So the bone that is going to be formed through osteogenesis. So we can see here viable osteoblasts and are transplanted with the graft material into the defect. عادة هذا تكون autogenous زي البون الإلياك بون كريست والميرو جرافت أو جرافتس من الشن أو الريمس. إذا احتاجنا نحن نسوي جرافتنج للإمبلانت سايت ممكن ناخذ من نفس البيشنت. طبيعة الجرافت هذه عندها osteogenesis, okay, and it can directly cause bone formation because they already contain the living osteoblasts. Conduction is a different thing. It's mostly done by allografts or alloplasts. Conduction, these are non-vital material. They serve as a scaffold. زي الصقالة شفتوا في المباني اللي يتسلقون عليها العمالة. احنا نحط non-living tissue نجيبه من دونر خارجي ما في cells حية عبارة عن minerals. فلما نحطه في السايت of grafting it conducts. الكوندكتور شفتوا في السيمفوني اللي يحرك السيمفوني كامل هو يتحكم بالعملية كاملة. فعندنا these grafts serve as scaffolds for the ingrowth. تسمح بدخول الأوستيوبلاست into the defect. This is mostly from allografts and alloplasts. What about osteoinduction? فاكرين لما قلت لكم البون مورفوجينيك بروتين ممكن يتوفر على شكل منتج تجاري لو حطيناه في السايت ممكن stimulate الstem cells اللي موجودة في البلد وفي السايت the location itself to form new bone. So new bone formation by the differentiation of local connective tissue cells or cells from the blood into bone forming cells under the influence of an inducing agent اللي هو الهرمون هذا. Okay. هذا يعتبر علاج نوعا ما حديث في البون grafting. So alveolar bone is mostly lost إما للتروما post extraction لو شلنا التوث يحصل فيه resorption or بسبب periodontal disease as we can see in the image here. Thus implant placement in the maxilla and the mandible may be affected by the lack of sufficient volume of the alveolar bone at the recipient site. عشان كذا مهم إن احنا ناخذ good anatomical radiographs to understand the remaining volume that we have that is required for the necessary treatment that is going to be done. Okay. So bone is the most important element. The most important element for any implant is that we have sufficient and abundant bone at the site. The prosthetic needs and desires should be determined, okay, and the number of missing teeth. And also based on the quantity and density of the bone, we can determine the implant size, its position, and also the number that we might require. Okay? Good. So bone, according to Lockholm and Zarb, there's a very classic classification that describes the density of the bone. Okay, this is subjective, it's not objective, it's very difficult to measure, but according to its shape and its structure, it was classified into 4 types. تلاحظوا لما يقول هذا type 1 bone هذا معناته انه homogeneous, mostly cortical bone, and this is usually solid kind of bone, وهذا very common في lower anterior mandible. Okay, عندنا type 2 thick cortical bone with a bone marrow cavity. Type 3 لو نلاحظ هنا نشوف cortical bone is slightly less, it's thin, and we have a denser trabecular bone of good strength. Type 4 is extremely soft. Okay, it's very difficult to place implants. And type 4, it's very thin. You have low density trabecular bone. There's another classification by Carl Misch. It's a similar classification as Lafholm and Zarb, لكن ضافوا هنا D5, which is mostly non-mineralized bone that is unsuitable for implant placement. Okay, so we have D1, D2, D3, and D4, and also D5 type of bone. So what about bone density? Okay, bone density is also important for the successive implants. It can be measured through cone beam CTs, through a unit called voxels. Okay, and usually we do that when we're trying to do scientific research studies. We want to compare between implants. It might be appropriate to know the density of the bone itself. Okay, so a key determinant for clinical success of an implant is the diagnosis of bone density in the implant site, the strength modulus of elasticity, and the percentage of an implant bony contact is related. كل ما زاد الدensity كل ما زاد البوني contact مع الامبلانت. The treatment plan should be modified by increasing the load. يعني لو كان عندي type 3 kind of bone ايش اللي ممكن اسويه؟ ممكن ازيد عرض الامبلانت. ايش اللي يصير لما يزيد عرض الامبلانت؟ يزيد معي السيرفيس اريا، يزيد معي البون to implant contact ratio. So if you have dense bone, we can use thin implants. We have unmineralized soft kind of bone, we can increase the density. شوفوا هنا الامبلانت 3.75. اوكي، احنا ممكن نوصل حتى 6 ملم. دقيقة. Okay, osseointegration. What is osseointegration? This osseointegration was first described in 1969, almost 60 years ago. Renmark published a landmark study showing that titanium implants will successfully osseointegrate with the bony structure itself, and it won't cause any kind of failure or anything of that nature. Okay, and it will not elicit a response from the body. Okay, and it showed that metallic surface bone can actually grow on a metallic surface of a screw. Okay, بعدين جانا Schroeder. Okay, later on وسوى description. Okay, لو تلاحظوا هنا what is its osseointegration is a direct structure and functional connection between a living bone and the surface of a load-bearing or carrying implant. Clinically, osseointegration is asymptomatic. Asymptomatic يعني ما له أعراض. It's a rigid kind of fixation of an alloplastic material in the bone, and it has the ability to withstand occlusal forces. Okay, when we look at the histology, you can see that bone forms around all of the surfaces of the implant and within the threads itself. Okay, by increasing the width of the implant, we're going to increase the surface area, and therefore we're going to increase the contact with the bone. The first person to show a histological evidence of osseointegration was Schroeder, and studies in the 70s and within the 80s itself. Okay, so زي ما قلنا احنا اللي نبغاه لما نحط implants لازم يحصل عندنا osseointegration. في حاجة ثانية اسمها fibro-osseous integration، وهذا عادة غير مرغوب في الامبلانت dentistry. يكون tissue implant contact with collagenous tissue between the implant and the bone. Okay, fibro-osseous integration زي ما قلنا is mostly happens إذا كان في حركة على الامبلانت تزيد عن 150 micron. So movement is not good. The movement will impair the differentiation of osteoblasts and will result in the formation of a fibrous scar, leading to fibrointegration. Okay, so we always want stability. Okay, so the implant itself and its healing is regulated by multiple factors. Okay, there are multiple factors that play a role into the success of the stability and long-term stability of the implant itself. Okay, so Implants, when we place them, we create osteotomies to place these implants, and primary bone healing. عندنا two types of healing, إما primary إما secondary. Primary معنات إنه the bone, there is well organized bone formation with minimal granulation tissue. يعني حطينا الامبلانت تكون عادة أضيق من الاوستيوتومي، أضيق من الامبلانت ب1 ملي، بحيث يكون في بريس فيت ويكون في دايركت كونتاكت مع البون حتى أضمن إنه يكون في primary healing. Second bony healing, okay. عادة لما أحط الإمبلانت في extraction site, the socket is larger than the implant structure, so it takes a while for the bone to travel until it reaches the surface of the implant. Okay, so osseointegration takes initially the healing phase. We have initial signs of bone formation within the first 4 weeks زي ما قلنا في laying of woven bone، لكن healing might take up to 1 year. remodeling يحصل من الشهر الثالث إلى السنة ونصف تقريبا، وبعد السنة ونصف نسميه احنا dynamic equilibrium. The bone is constantly modeling and remodeling around the implant after about a year and a half, which is almost 18 months. أول ما نحط الإمبلانت في أول 24 ساعة هنحط press fit زي ما قلنا، تكون direct contact by mechanical stability. Okay, occurs in the marginal 2/3 of the site. احنا عادة حيكون في blood formation وهيماتوما clot that will form around the implant itself. And this is slightly substituted with granulation tissue that is then replaced with bone itself. Within 1 week, okay, we're going to see cells, mesenchymal cells, and growth factors are released in the sites. The osteoclast will start resorbing the necrotic bone that happened due to the drilling. And this phase of bone, this wound healing is usually called modeling. Okay? At 2 weeks, لاحظوا at 2 weeks نبدأ نشوف الفورميشن of woven bone ويستمر إلى ال 4th week. Immature, slightly fibrous blood vessels, okay, irreversible lines, and the recipient site immediate implant shows resorption and also bone formation at the same time. So this is still unmature kind of bone. At 4 weeks, woven bone becomes the old bone is completely replaced with the woven bone around, so we can see the bone marrow spaces. It's highly vascular, and this phase is the first phase of true osseointegration. At 8 weeks, okay, نبدأ نشوف maturation، نبدأ نشوف osteons forming، نبدأ نشوف haversian canals, and the original bone will be replaced with a new lamellar kind of bone. This process continues up to 4 months. Okay, it's continuous. لاحظوا, it has a very mature kind of appearance compared to the woven bone اللي شفناه في initial phases of healing. وعندنا thin rims of lamellar bone can be seen in contact with the implant surface. Okay. What about occlusal load in the early phases of healing? Woven bone is formed in the gap between the implant and the bone. Okay, it forms in all directions. Okay, there's limited degree of mineralization with poor biomechanical capacity. This is why we do not recommend loading within the first month. We prefer that we wait to the 2nd, 3rd, and 4th month where you have more mature around this implant and higher stability. Okay. Osseointegration بشكل عام، Grenmark وصف phases of healing around the implant through an osteophilic phase, an osteoconductive, and osteoadaptive. So what does this mean? Osteophilic عندنا زي ما قلنا أول 48 ساعة، عندنا blood clot، عندنا cells تدخل المكان، عندنا ossification، okay, والformation of woven bone. بعدين عندنا osteoconduction, okay, which lasts until 4 months. وبعدين يصير عندنا mature bone، هذا اللي نسميه adaptation, osteoadaptive. عندنا thickening of the bony plate, balanced remodeling occurs. The final phase begins 4 months after implant placement وتستمر ممكن إلى سنة ونصف. تكلمنا على البرايمري هيلينج لما يكون عندنا direct contact مع البون، وتكلمنا عن secondary healing. When we have secondary healing, the formation of bone is called distant osteogenesis. Okay, bone healing from inward of the edge of the osteotomy towards the implant. Contact the direct migration of bone من السطح إلى على السطح مباشرة through the blood clot. Okay, we prefer to have contact osteogenesis when we're placing implant, but that doesn't mean we can't do immediate implants. No, we still have bone formation, but healing is different. It takes slightly longer, and we have to take into consideration the type of implant placement. So what factors affect osseointegration؟ عندنا implant related factors، شكل الزرعة، طول الزرعة، عرض الزرعة، نوع الزرعة. patient related factors related إما systemic diseases, oral hygiene, smoking and so forth. وعندنا surgical factors، هل تم وضع الزرعة في بيئة معقمة؟ هل بيئة مبردة؟ هل تم استخدام saline أثناء البليسمنت؟ So also these things play a role. Implant factors زي ما قلنا shape of the implant يفرق، the size of the implant، apical design. tapered implants هذه حلوة في immediate implants لأنها it acts like a wedge. So we choose the type of implant based on the necessity and the need and the location of the missing tooth itself. We also have surgical factors. Okay, لازم profuse irrigation في السايت و good cooling, very sharp drills. Okay, عشان ما نستخدم dull drills وتسبب لنا necrosis في البون. Heat should not exceed 47 degrees Celsius, and we also need to do this in a very aseptic technique, very good and clean and septic site. Okay, these are very, very critical so we don't get secondary infections. Patient-related factors: العمر, density, compliance, smoking, vitamin deficiencies, any uncontrolled kind of disease is a no-no for implant placement. We should control, refer to a physician, control systemic factors, and then we can start planning for implants. So لما نحط الامبلانت عندنا primary stability achieved at the time of surgical placement، هذا اللي نبغاه، الامبلانت تكون ماسكة. طبعا primary stability is affected by the geometry of the implant وبرضه the quality with density of the available bone. Secondary stability لما نحط مثلا الامبلانت في extraction site وننتظر إلين يصير distant osteogenesis، ف healing is achieved over time. stability يعني يحصل نتيجة للوقت والhealing. It's also affected by the implant design وأيضا the quantity and quality of the bone. طبعا anterior mandible has dense cortical bone يعطيني very good primary stabilization, whereas posterior maxilla عندي thin cortical bone. Okay, sometimes this is good for stability، لكن أيضا لما يكون في dense cortical bone في blood supply يكون أقل، وبالتالي the highest site for implant failures is the lower anterior mandible. Soft tissue interface is also important. لو تلاحظوا في normal tooth عندنا fibers, okay, part of the gingival fibers that come from the gingiva and insert themselves into the cementum of the root. In the implants, this is not present, okay. لو تلاحظوا the mostly bone is in direct contact لكن ما في communication between the fibers and the implant surface, okay. البيولوجيك width هذا موجود في الناتشرال تيث، عندنا أيضا biological width في الامبلانتس، بس بسبب الأورينتيشن والpresence of the abutment itself ممكن البيولوجيكال width يكون أكبر شوي، تراوح تقريبا 4 ملم compared to 2.8, 2.9, 3 millimeters in natural tooth. الابيثيليوم بشكل عام الsulcus formation is similar to the sulcus of an implant، لكن due to the orientation of the fibers ممكن يعطيني slightly larger reading of the periodontal sulcus when we're probing. So probing depths may be 1.5 millimeters higher in implants. This is why we should be very careful when we're probing around implants. Okay. Keratinized tissue مرة مهم. زي natural teeth, we have to have at least 2 millimeters of keratinized gingiva around the implants or the tooth, and they're also susceptible to implant failures, gingivitis. لكن في الامبلانتس حنسميها peri-implant mucositis، ولما يصير في bone loss around the implant وفي زي disease نسميها احنا peri-implantitis. Okay. Vascular supply هو نفس vascular supply around a natural teeth. Okay, and then capillary loops which is one electron scanning microscopy here. Okay, all these blood vessels form loops within the gingiva itself, and the inflammatory response to plaque is similar to natural teeth. The comparisons between implants and teeth are very important. Okay, so go over them. Teeth have proprioception في إحساس, but this is absent in implants. And then هنا في natural teeth عندنا periodontal ligament. We do not have periodontal ligament. The connection is rigid and it's asymptomatic. التيث ممكن يصير لها supra eruption, بينما الimplants cannot intrude or migrate either naturally or from orthodontic therapy. Okay, implants are contraindicated in individuals prior to growth, لأنه ممكن يصير أثناء الجروث تبدأ يصير supra eruption للتيث. لو حطيناه في سن مبكر الزرعات ما تتحرك وبالتالي حيكون عندنا disturbed kind of occlusion. How do we evaluate osseointegration? Okay, في invasive method هذه نستخدمها في الأبحاث. ندخل ونشيل تريفاين ونشيل الزرعة مع البون ونقدر نسوي examination histologically. Okay, والنون invasive هذا اللي عادة تصير في العيادة في sensors هذا اسمه Ostel. Okay, يسوي vibrations tapping with a metallic instrument ويعطيني reading. Okay, mostly above 60-70 means that we have good primary stability and this tooth or this implant can be restored. Okay, في جهاز زي البيريو test can also be used to determine implant stability. Failures of osseointegration إما تيجي مبكرة. Okay, حصلت خلال ال4 أسابيع الأولى or late يعني بعد 4 شهور رجع البيشنت بعد 6 شهور إلى سنة وبدينا نشوف حركة في الإمبلانت هذا late failure. عندنا biologic تحدث في أول 3-4 أيام نتيجة لحدوث bacterial infection وعندنا mechanical ممكن جاء كسر overload or fracture of the implant itself. Okay, and here are samples where we can see failure of osseointegration, cupping of the implant, presence of disease. In this picture we can see a fracture of the implant. Here the implant is placed too buccally. In this image we can see that on the top, in the middle and the top, you can see that these implants do not have sufficient keratinized tissue and there's a presence of an aberrant frena. So in conclusion, thorough understanding of bone biology is essential for clinicians to fully appreciate the phenomena and limitations of osseointegration. Bone to implant surface interface with soft tissue interface plays an important role in the long-term maintenance. Okay, clinicians must update themselves for future evolution of implant design and protocols, how to surgical placement, anواع restorations, and how to maintain implants. Thank you very much for attending this lecture. Please read these slides. I uploaded the PDF for you to go over, and I will also send a copy of the 2 chapters for you to read. Thank you very much and have a nice day.